event about Syrian refugee health and health services delivery in Jordan and Turkey, Project Aspire. I want to thank all of you on the live stream. We don't only have people here, but we have a number of people on the live stream, so welcome. And I would like to welcome two important people in this room, Dr. Maysa Kadra, who came from Jordan to participate in this event. Dr. Maysa Kadra is a professor at the medical school at Jordan University. She is also the principal investigator on Project Aspire in Jordan. She has been heavily involved in project and put so many hours and so many days in making this happen. So thank you very much, Dr. Maysa Kadra. And the other person that I would like to welcome is Dr. Denise Okazakar from Turkey. She is professor at the University, Istanbul Aydan University. She's a professor in the political science department. Thank you very much for being here and for your hard work. Denise has been involved in the project from day one, and because of her vision, her really dedicated time, we succeeded to do this work in Turkey. So thank you, all of you, for being here today. I also want to thank many of the people who have been engaged in this research from Columbia University and from a School of Social Work. We have students, we have pre-docs, we have postdocs, and we have a leader with us here. Her name is Dr. Dasgupta, who has worked so hard to make this happen. Dr. Dasgupta not only dedicated her time at the school, but she traveled all the time to these countries to make this happen. So I want a special thank to Dr. Dasgupta. But also I want to thank in the room the people who funded us to do this work. We started this work by funding from the President's Global Innovation Fund, and then we really were lucky to have friends of Aspire who funded us to do the work, who in fact funded us to be here today, and they are in the room. So I want to thank them very much for all their contribution, and they continue to work. Really, thank you. Because of your funding, in fact, we are here today. We were able to afford to have this event. And finally, I want to thank Insight, especially Dr. Peter Berman, who supported us. So thank you all, and I hope you'll enjoy the event. Before we start the event, I want to call my colleague, Dr. Niraj Koshel, to welcome you and to talk a little bit about the involvement of students and faculty in the project and where we're going with education, training, and research with the project. Niraj.
Hello, everybody. I would also like to welcome all of you, and I see several collaborators here, several funders here, and several dear colleagues, and I want to thank you and students, PhD and other students for coming here and attending this event. I think I want to, before I speak a little bit about Aspire, for those of you who are taking this as a credit, for a fee, NYS, NJ, and CT licensed social workers and NYS licensed mental health counselors are eligible to receive 2.0 contact hours, whatever that may mean. I don't know what it is, but I'm required to read this. In order to receive your continuing education certificate, you must attend the entire event and complete the evaluation. Certificates will be emailed within 3 weeks of the workshop, and once evaluations are completed, participants joining via live stream will be emailed a link to complete the feedback evaluation and answer 2 to 3 questions regarding the content. Welcome those who are taking this for credit. Now, Aspire, how it was initiated. Nabila just told you part of the story. It began at the peak of the Syrian refugee crisis. We were sitting here and we were thinking we need to do something about it with Professor Dasgupta and Indita Dasgupta's work And with Nabila and I, we wrote a grant, and we were very lucky to get funded with that. The three pictures that you see here were at Zatri refugee camp in Jordan. This is the biggest refugee camp of Syrians in the world. We went to this camp on our first visit to Jordan, which was funded by the president's funding that we received. You see me here in one picture, very grim looking. That's because I walked into a huge store which was operated by the owner of the store in Zatari camp was a refugee. And I was very impressed initially. My first thought was, wow, huge store. Everything that you could think of was available in the store. But then the reality sunk in. Actually, we had a little video of it earlier. We don't have it now, but at that time, one of my colleagues made a video when I was interviewing the refugee. This gentleman lived in Damascus and worked there with the government. He had to leave with his family. And so he was living in Zatri camp where all kinds of restrictions are imposed. You cannot leave the camp. You can only leave it for a couple of weeks. And once you leave, you have to get government's permission. So all kinds of restrictions are imposed on them. And he had to live a very different life. He never thought that he would be living like a shopkeeper who would be supplying goods to people in that camp. His whole life had changed because of this incident. While we were talking to him, one of his sons walked in, who was a graduate in computer sciences, but he didn't know what to do with his life. He didn't have any job at that time. Aspire, therefore, got much more involved after our visit to both Zatri and another camp in Jordan. We got a lot more involved, more committed on this project. We had several meetings with colleagues in Turkey, and that's when we realized that we need to address the needs of people who are providing services to refugees. Nobody thinks about what they need. And you will hear from one of our leaders in Turkey who has carried out this survey on service providers in Turkey. It's a multidisciplinary consortium. Aspire now has become a multidisciplinary global consortium. We have received funding from several places, but more what we are really proud of is student involvement, not only from Columbia, but from outside of Columbia in New York City, other universities, NYU, CUNY. We also have students, our collaborators in Jordan, as well as in Turkey. And here are some of our photographs as we visited these places. I think I will call Nabila back and talk a little bit about the global refugee crisis and its various dimensions.
Thank you, Niraj. I want to highlight and thank many of the students who are sitting here. Without your support and help, we will not really be able to complete this study. So now we are going to be moving to create the context of the Aspire project in Jordan and in Turkey. But before we begin, I want to remind you that the global refugee crisis is huge. It's happening in Syria, and it's happening in many, many different countries. As you see in this map, globally, up to mid-2018, there were 26 million refugees. And you can see here in this map where the 10 locations that have the highest number of refugees. And this number is growing, and you'll see at the end of my presentation where the numbers are growing. But we ask ourselves, who is paying the price for this crisis? The majority are women and children. And when we looked at the data, we realized in these 10 locations, the percentage of women who are refugees range between 85% to 66%. And if you look at among Syrian refugees, 66% are women and children. And if you look at the percentage of girls that younger than 18, as you see in this map, the percentage went from 31 to 21%. Again, among Syrian refugees, the percentage of girls who are less than 18 is 21%. And then we looked at women that are older than 18 in these 10 locations. And again, women who are older than 18 pay a huge price. The percentage of women at this age range between 25 to 23%. Again, among Syrian refugees, women older than 18 account for 23%. And if you look at the most recent crisis among Rohingya, women are paying a huge price, 21.2%. So this is the global crisis, global problem, and we continue to see that women are suffering from this crisis. I also want to mention that there is a new crisis. We're not including it in the map because the data that I presented is up to mid-2018, but there is a new crisis, which is among Venezuela, where there are 3 million refugees. So if you look closely at the 2 countries where we conducted this study is Turkey. Turkey has 3.6 million Syrian refugees. And these are registered refugees. And if you look at Jordan, there are 660 registered refugees. And again, the majority are women and children. Where are they living? They're all living mostly outside the camps. And as Rina Raj described, they're really outside the camps, and they're trying to be integrated into the communities. And today, in our presentations, you'll see that the refugees, the Syrian refugees in Jordan and in Turkey, facing many challenges to be integrated in the community. And one of our really interests is also to come up with ways that we can help the women to be integrated and receive services that they need in the community. So what did we do in Project Aspire? Project Aspire in Jordan focuses on women. We interviewed 507 women, and we looked at the lives of the women, and we included only women older than 18. We looked at the history of displacement. We looked at their health, sexual and reproductive health. We looked at chronic diseases, healthcare utilization. We also looked at health and mental health issues such as depression, anxiety, post-traumatic stress disorder. We also dig into their gender inequalities experiences. Especially, we looked at early marriages, social norms, gender-based violence, and participation in education and in labor force. Where we recruited women, we recruit them from non-governmental healthcare clinics. We have data that we will share with you about the 507 women. We will share with you not all the data we have, but we will show you the context that this woman lives in. We will show you a little bit about reproductive health, about gender-based violence, about gender inequalities. And I'm hoping that by the end of this event, we can share with you what our next steps of doing research. And as you know, we do research to make a difference. So what you will see from Dr. Dasgupta's and others in presentation that the findings, the research we did, really is to make an impact in women's lives. Secondly, the study in Turkey is different. It's different in a sense. We did not focus on women, but we focus on providers. And you may ask us, why did you focus in Jordan on women, and in Jordan you focus on the providers? And I have to say, the first visit in Turkey, we visited a lot of NGOs, and we learned that one of the NGOs treat 1,000 refugee clients a week. And the providers we talked to, the health providers, told us, we face a lot of challenges. We face stress from the work. We are facing post-traumatic stress reaction, given we are listening to many stories of the refugees. We also don't have all the tools that we need to address the needs of the population. So talking to the providers, being there, and to the scientists, we said, maybe the first step is really to work with the providers, understand their needs, And the next step is to come up with training protocols and models that can be used in intervention approaches for the providers. So we started with the providers. What you'll hear today, a study that used mixed methods. And Dr. Denise from Turkey was here. She's an expert in qualitative methodology, and she has done an amazing job in this area. And you will see a combination of qualitative and quantitative with the providers. We'll give you some findings about the post-traumatic stress disorder level that the people live with, the providers, the depression and burnout, discrimination and biases, and perception of the providers against the refugees, and some data on discrimination toward the providers because they serve, which is really an amazing issue, because they serve Syrian refugees, there is a stigma against these providers. And you'll hear from Denise about these issues. We went to 17 NGOs in Istanbul, and we interviewed 104 interviews from the providers, and that was quantitative interviews, and 20 quantitative interviews. Today you'll hear about both. So again, I want to thank Dr. Maisa Qadra for working so hard in Jordan, and also Dr. Denise Zakir from Istanbul for working so hard. I am really looking forward to your presentations, but this is the beginning of our activities and our research. We'll hear from the speakers, and Dr. Dasgupta will end the presentation today by tell you some of our thoughts and ideas in how this work is going to go to the next level. Thank you, and looking forward to your presentations.
Hello. First, let me thank you, everyone, for coming today. And thank you, everyone, for bringing us here, including our collaborators, our team from Turkey, our fundraising group, and the students. It has been really a pleasure to work in this project. Global research is not easy. I have learned a lot from this research in all aspects. And hopefully we'll meet more and talk about that. So today I'm presenting our findings along with Dr. Dasgupta about Jordan, and we named our study Women Aspire. So Dr. Al-Basel explained how this research started, and we initiated a collaboration between Columbia University, the Global Center of Columbia in Amman, and the School of Medicine in the University of Jordan, as I work as an associate professor in the School of Medicine, Department of Obstetrics and Gynecology. So when we first started the study and wrote the methodology, we looked into which areas we should work in, and we did literature review, and we decided according to the study. So if you see these cities here, so Amman is the capital of Jordan, and more than 35%, according to one of the UNHCR reports, 35% of refugees live in Amman, 27% live in Irbid, Ramtha, and this is another city called Zarqa. So about 73% of women live, of urban refugees live in these areas, and we chose these areas. Then we looked into what NGOs or what organization to find our population, the study population. And we found the Institute of Family Health and the International Rescue Committee. And we chose those because they have a clinic in this highly populated areas. And so we chose IFH, which is the Institute for Family Health and the International Rescue Committee. And then, as we talk, these photos are of our big team in Jordan. So we established a team of research assistants, medical students, and we had a lot of visits from our team here. This is Adam and Anandita visiting us in Jordan, where we have run training for our research assistants in terms of ethics, in terms of data collecting, in terms of completing the survey. So we have done a lot of training for the student and the research assistant along with doing the data. So going to the findings now. So 73% of the women came from Aleppo, Homs, and Daraa. And if I go back to the last slide, sorry about that. If you noticed, these three cities were the cities we chose were in close proximity to the cities I'm mentioning now. So 73% of the women, they moved from Aleppo, Homs, and Daraa, and around 68.6% of these women, they moved around in Syria before they moved to Jordan. But and most of the women, around 73%, they left Syria between the years of 2011 and 2013. And according to one of the UNHCR reports, that most Syrians living in Jordan now, they have moved to Jordan more than 2 years now. And people who moved to Jordan, they directly moved to, from Syria to Jordan. Okay. The mean age of women participating in the study was 34 years, and more than 65% of the women participating in the study can read and write. Around 20% have reported that they have disrupted their education because of work, and 90% of the women were currently married, and the other 10%, they are either divorced or they are widowed, and we only have one single woman. Most, and the household profile, around 80% lived in renting apartments. The other, they were using in non-real camps, or they were using just spaces which were empty. So if they are not living in renting apartments, they were living in a worse situation, actually. The mean household size was 5, so 5 people lived in the households, and this is consistent with the last report of the UNHCR. People around 2/3 reported food insecurity in terms they relied on less expensive food or borrowed food. Most of the women, or all of the women, they had no savings, and the primary source of income was reported to be UNHCR. Around 70% of women reported they lived in the refugee camps, and despite saying they are camps, you have to think of them as camps which are well established, especially the Zaatari camp, if you remember from your visits. So these camps, they have houses, concrete houses, they have shops, they have salons, they have everything. Despite that, around 95% of women, they believe that they had a much better life outside the refugee camps. Basically, from what Niraj said before, because they have a lot of restrictions if they are inside the camps. So they have to have clearance, and they have limited time to go. And so, okay. So we looked into non-communicable disease. As if you remember from my previous slides, most women, they have lived in Jordan for about 7 years now. So most of them, we said, they lived in Jordan, they moved to Jordan between the years 2011 and 2013. So they lived in Jordan basically around an average of 7 years. So we looked into non-communicable diseases and the prevalence of that. So anemia was found to be in the range of 62% in these women. Blood pressure was reported in 24% of the women, gastric ulcer in 13%, the diabetes was around 10%, thyroid disease 12%, and kidney disease is 9.9%. We have reviewed the UNHCR previous reports. Our numbers are slightly higher than that. We are looking at specific population of women. And we noticed that the number of anemia is more. So the last report was in December 2018 about the health survey conducted by the UNHCR. They reported anemia to be 40%, and that's general population, while we are comparing to women where they had pregnancies and they had more sufferings. Okay. Being an OBGYN, I was really interested in sexual and reproductive health. So, in pregnancy history, women reported around 95% being pregnant before, and the average number of pregnancies was about 5, and it ranged from 1 to 17. Around half of them, they reported miscarriages and family planning. So most women received good counseling and good contraception options, and most women, like 70%, used modern contraception in terms of intrauterine contraceptive devices, combined pills, all these modern contraceptive. And around 43% reported that once they became refugee, they decreased their family planning goals in terms they wanted less children. Being a refugee, they wanted less children. So, and about prenatal care. So, antenatal care in Jordan, so the policy towards Syrian in terms of health services differed in Jordan. So initially they were given free services, then it moved to subsidized prices, then so we had a lot of changes. At the time of doing this research, actually, it was just moved to being they have 80% of foreign prices. Before it was the rate of the insured Jordanian. Yet antenatal care and children care, especially vaccination, was always covered by the government. So they had a pretty good prenatal care, around 80%. It was very interesting to see this number of home deliveries of 17%. It's really a really high number, and we are looking into that. 77% they have delivered at medical services, either private or governmental. Caesarean section rate is 26.6. It looks high, but honestly, that's a norm now in Jordan and globally because of many issues regarding medical legal issues with OBGYN. The rate of Caesarean section is in the increase globally, to be honest. So this number is consistent with the numbers now. About birth complication, we have a postpartum hemorrhage of 12%. Again, it is doubled the normal. Maternal postpartum hemorrhage is the leading cause of death in the developed world. And 12% is much higher than the global figure of 6%. The rate of wound infection is around 19.5. Again, this is a much higher number. The reported rate differs according to the area, to the hygiene, the population you are studying, but the highest reported was around 15%, and this number is much higher than that. And again, surgical site infection could lead to sepsis, which is accounted as the third number of maternal mortality worldwide. And allow me to bring Dr. Dasgupta to the audio. Thank you.
Great. Good afternoon. And thank you, Dr. Khadra, Dr. Al-Bassel, and Kaushal for the great introduction. It is wonderful to see everybody here today. So I'll continue where my colleague left off, and I'll start talking about some of the mental health issues. And I want to acknowledge some mental health experts in this room as well. So looking forward to hearing your questions at the end. So I don't have to explain to this room that mental health is a global health concern, correct? And in refugee context, humanitarian context, mental health is even more of a concern, I would argue. So for our study, we used a number of validated measures, and I've listed them here next to each item. And we wanted to see what the prevalence of each disorder was. So in terms of depression, we found a very high prevalence. 62.9% of our population reported symptoms of depressive symptoms. 89% reported having symptoms of an anxiety disorder, and about half reported symptoms of post-traumatic stress disorder. On top of that, we looked at questions around suicide. And so to start with, we asked about suicidal ideation. And about 9% of our samples said that they had suicidal ideation in the past 6 months prior to survey. On top of that, and this is really the most staggering to me, in their lives, people had reported, almost 10% reported attempting suicide at some point. And among those who reported attempts, almost 30% had attempted a suicide in the 6 months prior to survey. So these numbers are even elevated from what we found in existing reports from UNHCR, from IOM, from numerous agencies. And so there's a lot of conversation that we can have about metrics around mental health. And I think this is an important step around that as well. So my area of expertise is in terms of gender inequities of health. And I wanted to bring light to gender-based violence in our study. So again, to this audience, I don't think I have to explain this, but gender-based violence is, of course, one of the most egregious human rights violations. In our sample, we looked at violence in a couple of different ways. So to start with intimate partner violence, so this is violence perpetrated by husbands against wives, we found a very, very high prevalence rate of physical violence. So 50%, almost half of our population reported experiencing physical violence at some point in their life. And the 6 months prior to survey, almost 30%. Sexual violence was lower than we expected. It's about 7%. And in the past 6 months, it was about 4%. So these numbers, before I go into family violence, are actually also a lot higher than what we've seen. The World Health Organization states that 30% of the population has experienced some form of women have experienced some form of violence at some point in their lives. And these are much, much higher than that. We also asked about family violence. So this is violence perpetrated by somebody in their family. And we found a decent prevalence rate of 23.5% of lifetime violence, physical violence, and quite lower for the last 6 months. So going on the theme of gendered inequities of health. So early marriage, often described as child marriage, so this is marriage prior to the age of 18. This is often done in stable settings, in other settings as well, in humanitarian settings. But we know that one of the major drivers for early marriage is really poverty and unstable settings. So we know from other studies and other settings that early marriage is often exacerbated, just like gender-based violence, in times of conflict and other stressors, often as a means of protection for their girls. This is further compounded when populations have norms around early marriage prior to conflict as well. So in Syrian culture, there was already a norm of early marriage. 13% of Syrian girls were married, let me get this right. 13% was the prevalence for early marriage among Syrian women in Syria before the start of the conflict. Similarly, in Jordan, the prevalence rate for early marriage was 8% before the conflict as well. So, taking us to our study, we actually found a prevalence rate of about 40+%, almost 50% of our sample had been married prior to the age of 18. And if you look at the numbers that I have up here, you can see that it's really split almost evenly between those who are married before they were 15. So these are, I would say, some of the most vulnerable girls. And then those who are 16 to 17 was about 25% of the population. We asked about if they had been married prior to the war or since the war. We found about 14% had actually been married prior to the age of 18 since 2011 when the conflict started. And I wanted to, we're really talking about what I've described as flat descriptives in this presentation. We're not looking at associations. We're not testing for greater details right now. That is our job coming up. But I did want to give a little teaser. So I looked at one of our questions that asked, were you happy with the age that you were married, essentially? And I looked at it between women who are married before they were 18 and those who are married above 18. And I think one stat in particular is interesting. So 40% of women who are married before they were 17 said that they wish that they were older when they had gotten married. And you can compare that to women who are married when they were 18 and above, and only 14% of those women said that they wish that they had been married at an older age. And so this is a great example of associations that we can test for. We can't say, of course, that there's a significant difference between these groups right now, but that is just the start of the research that we will be able to start to look at and drivers of early marriage moving forward. So thinking really about healthcare. So Dr. Khadra presented some stats about diagnoses that women had in our study. And so we wanted to highlight some of the top self-reported barriers to medical care. It's important to note that the vast majority reported that cost was a major, major barrier to medical care. There were some others, and this is pretty consistent from other developing settings as well. Issues with transportation, childcare, refugee status seemed to be an issue. These are all pretty consistent, but I think the cost issue is really something to think about. And I wanted to highlight actually that this is potentially could be related to the fact that the Ministry of Health in Jordan, which offers some of the most comprehensive and really phenomenal healthcare in Jordan, up until 2014, they were offering services for free at Ministry of Health clinics. And then starting in 2014, they started charging Syrian refugees at different rates. And that rate increased over time. In January 2018, the rate increased to the highest amount, and our study started a few months after that. So this is something that we can dig into quite a bit, and we're really looking forward to that. And so I want to end this part with something kind of positive. So I feel very lucky to be working in the social intervention group, and something that has really brought us together is really talking about not doing research for the sake of research alone, really thinking about that next step from the beginning. So Dr. Al-Basila has so much experience doing this type of intervention work, especially around economic empowerment. So she suggested we added in questions around feasibility and acceptability of a potential economic empowerment intervention for women. So we asked, we said, are you interested in learning financial skills? Almost half said that they were. Over half said that they were interested in starting a business. And I was very excited and surprised by this, but on average, women said that they were available for 9 hours a week to do something else. Industries that people were interested in: sewing, cooking, teaching, housekeeping, healthcare, I think is really interesting, especially in terms of potential interventions, especially when we're thinking about reproductive health, even early marriage, and technology. And then I just wanted to point out this one last thing. Almost 20% of our sample said that they were the heads of their household. And I think this is a really important, and I've included the definition for how we've described that. And I think it's a really important point to make, especially as we're thinking about implications in the future. We're in a situation where some women are saying that they are the heads of the household. I think that gives us a great opportunity to think about interventions and empowerment moving forwards. All right, so now we have a little treat. And so we have an incredible video that was made by Louis DiCaprio. The director, can you wave? And Thaddeus DiCaprio is one of the producers in conjunction with Meal Productions. And so they traveled with us to Jordan and made this incredible video. And so you can hear directly from our incredible team on the ground there. So thank you. I can get this to play. That's it.
Jordan specifically hosts over 1 million Syrian refugees and needs support desperately on how best to address the needs of Syrian students. We have a wonderful team of research assistants in Jordan who are conducting quantitative questionnaires that are based on the highest level of rigor. To our knowledge, Women Aspire is one of, if not the only research study that employs such rigorous methods to quantify the gender health and mental health concerns of Syrian refugee women. We get to touch upon many intimate issues that even for many participants it could be stuff she's never considered. It's got to do with her very personally as well as her health. When you're asking them the questions pertaining to violence, for instance, many of them would laugh it off in your face while still answering, yes, he has done X, Y, Z in the past. But she's not actually focusing on it, she's actually just laughing it away. You start thinking, but why is that? I remember just one of the most recent ones when we were asking her about whether he has attempted or whether he has sexually assaulted you. She replied something along the lines of, oh, it wouldn't matter, my soul is dead anyway.
أنا كنت عم تواجه مع حدا عم تسمعي عن تفاصيل حياته تقريبا ساعة، تعلمي كيف تتعاطفي مع هذا الحدا. هلا عادة نحن في الوضع الطبيعي لما حدا يكون زهقان أو ملان من البيت تبعه بصير يحكي إنه أنا صار لي فترة مثلا بين 4 حيطان. عملت مرة مقابلة مع حدا اكتشفت إنه ال4 حيطان اللي إحنا ممكن نكون زهقانين منهم هي ممكن تكون حلم لشخص عايش في خيمة صار له مثلا 6 سنين خلال قدام. وبتذكر مقابلة تانية عن السؤال عن الأكل وهي الأشياء، فصارت تحكي لي إنه أولادها كثير زهقوا من إنها هي عم بتطعميهم رز أبيض دائما مع لبن، فهي صارت شو تعمل عشان تغير لهم وتخليهم ما يحسوا بالملل، صارت تحط لهم مسمى أحيانا عليه، تحط لهم سمسم أي شيء إنهم يحسوا إنه هي غيرت. عن جد فعليا ناس ثانيين ما بيحلموا أو مثلا ما عم يقدروا يجيبوا هذا الشيء.
I'm going to talk about a story that affected me when I was doing recruitment. One of the women that I approached, I told her about the research, and then I told her, I want to ask you some questions about if you are eligible to do this research or not. But the strange thing that she called her husband, and her husband started to answer the personal questions. So this is really very hard, that you don't even have the right to talk about yourself in even simple things. Yes.
As a professional, we didn't want to do research just to follow research. So we don't want to do research just to do research. We want to do research in order to help us to find implementation policies, interventions that can help the Assyrians plus the country in terms of the Syrian crisis.
What we want to do is create innovative interventions, tailor them based on the data that we've already collected, and then help organizations evaluate whether or not those interventions really work or not. That can then lead to long-term change. It can lead to sustainable programs and policies, and we've done this in other countries. What we've been able to start up in 2 years is incredible. There's so much momentum. There's so much excitement. We want to capitalize on this and use funding from donors, from agencies, to really create positive change and to create positive and lasting health impacts for Syrian refugee women. Syrian refugee women, especially, they need help right now. We can't wait.
Compelling, yes? Okay, so now we are going to, right, so now we have time for a few questions. Do we have 50, are we okay on time? Go ahead. You can use the microphone next to you. I'm just getting these for.
Thank you. I'll just speak loudly.
Actually, can you push the button just because we have people on the.
Oh, okay.
Yeah, I'm sorry.
Okay, thank you for coming. I just have one question regarding one of the data points that you made when you were talking about the satisfaction with the women with their marriage, and you divided into younger than 17 and greater than 18. What was like the cluster, like what was the mean age group of the women you interviewed that were greater than 18? Like, were they between like 19 and 21, or were they older, like in their 30s? And then what were the age group of women younger than 17 in terms of like how widely distributed they were across the women that you interviewed?
It's a great question. We actually have not looked at that yet. So I don't want to hazard a guess until we've actually looked at it. But I'm glad you're asking the question, because that's exactly the type of distribution and analysis that we want to do. And we can add in other aspects of it, right? Like we can look at drivers of different issues in terms of reproductive health and looking at those clustering around the age groups and the interquartile ranges as well. Great question.
Is this on? Okay, cool. I was interested in the kind of like slide you had about what women were interested in doing, like financial literacy, starting businesses, and I was curious about this kind of that high interest in starting a business. Like, do you have a sense of what makes that attractive for your respondents, or kind of what models do they imagine when they imagine starting a business?
Well, actually, I think it depends on their expertise. So if you remember, it was sewing and cooking. The high numbers were sewing and cooking. So that's their expertise. And actually, even in Amman now, we have a lot of and it's socially very acceptable and with no stigma now that women in Jordan, so the education level is getting more. So we order food more. And so it is very acceptable, and it's becoming like a job that women are getting more into cooking, either Jordanians or Syrian, but Syrian food is very good, and Syrians are very good cooking, so that's one of the reasons. And they are very good at sewing, and I think that's why was their interest.
And just to add to that too, I think also it's important to remember where we recruited our sample from as well. So we're really, really lucky to be working with International Rescue Committee and Institute for Family Health. And we know that there have been a number of microfinance, lending, there are a number of projects in the region. What I would say is that there are a lot of projects and interventions already, so I think that this idea is there. But I will say that I don't think that there are any interventions around economic empowerment that really focus on addressing gendered inequities in combination. And then really thinking about rigorous evaluation and implementation science and sustainability. So I think that those data really show that there's excitement and there's need and there's potential. And I hope that we can find funding to take it to that next level.
Mm-hmm. Good.
So I have two questions. One, you said that there were about 9.7 suicide attempts. I wanted to know if there were any people that died by suicide, and also if you know what the infant and maternal mortality rates are.
So great questions again. So in terms of the suicide attempts, so they were not successful. So these were the women who were answering the questions at the time. So they had attempted suicide, but they were unsuccessful. And just a note, again, highlighting our partners, they have actually really good services around mental health. And so we had a lot of important referrals that were made and all of that as well. But so these were unsuccessful attempts. Infant and, did you ask infant and maternal? Yeah. We don't have those rates right now. We have the data to show it. We have to drill down a little bit further in terms of the cleaning. So this is fresh off the survey. So we will definitely have that. I'm surprised that wasn't your question too. Yeah, Golene, go ahead.
I just have, okay, can you hear me? Hi, Golene Samari from Mailman. My question is about the child marriage and fertility data. So some of the research coming out of Jordan on Syrian refugees is showing that the elevated rates of child marriage are because of a selection issue from certain regions in Syria where child marriage was actually elevated similar to those rates. And so I think it's important that you have the migration history information, because I think that it's important to look at the selection of the sample and whether it's actually sort of a selection issue overall reflecting pre-migration behavior, or if there was really a migration change leading to a behavior change. So your thoughts on that?
Yeah, it's actually very, very exciting, because we have the larger cities that we just described that Dr. Kadri explained, but we also have very small, even village level information. So we can actually get to that level. And we have an incredible master's student, Hani Almoush, who's not here today, but he is Syrian and has been helping us kind of think through that. But I agree, I think that's a really important point. And so again, these are all ideas for analysis. So we're very excited to do that. Tim.
Thank you for such great work and presentation. I was wondering if you had looked at or planned to look at structural or policy-related issues that impact, for instance, early marriage. Within Zatari, for example, are there policies that actually promote early marriage based on kind of certain benefits that are available to married couples? And then when you're thinking about your intervention, are you looking at some of the barriers or facilitators between spouses that might impact empowerment, as well as on a policy level in Jordan? Are there changes in the way that Syrians or, for instance, non-Jordanians are allowed to have businesses, et cetera? Are you looking at those as facilitators or barriers?
Yeah, also, I mean, these are just great research questions. I feel like we have a set of papers that we can write now, in addition to the ones we were thinking. So yes, those are all things that we were thinking about and planning on examining. So one thing in particular in terms of couples and thinking about barriers, facilitators and barriers in terms of the intervention for economic empowerment. So, I mean, Dr. El-Bassel is one of the foremost experts in couples research as well. So part of what we would actually want to do and we would consider is really thinking about what type of barriers within the couple might actually exist, or the household, around gender dynamics, to really think through, okay, I don't think it does a lot of good to create an intervention where we are empowering one person and not preparing the rest of the family and thinking about that. We can't ignore the gendered context if we're not doing that. And then your larger question in terms of thinking through this larger structural factors, yeah, those are pieces that we're considering and we have to figure out how to account for in the analysis. And we actually, our incredible research assistants and research coordinators, they've kept track of major policy changes and things that have happened in the region during it. For instance, actually the Syrian border between Jordan and Syria opened during our study. So that's also something to consider, especially in terms of migration. So we have a big task ahead of us to really talk through and think through these pieces.
Hi. Sorry. So I was interested in the results about sexual violence, and I was wondering if you could tell me a little bit more about how those questions were asked and like what the responses were kind of like, just in terms of, as a Syrian myself, I know that in our culture, since most of the women were married, that marital rape is not a thing, and it's, to them, you cannot get raped by your husband. It's just like not. It doesn't work like that in their definition. I was just wondering a little bit more if you could tell me how those questions were worded and how they kind of reacted to them.
This is a great question, and we, Dr. Albassel and I especially, have been having long conversations about this. So we used validated measures to look at sexual violence. We used the revised version of the conflict tactics scale. So for sexual violence, there are two questions that are used. One is, were you forced to have sex when you didn't feel like it? And then the second was, I can't remember now, I'm blanking now. But anyways, there's two questions that are the CST scale. And so for those two items in particular, we used a translation also of those questions that had been used with the population as close to our target population as possible. So this was used with Palestinian refugees actually a long time ago. So that's all to say, we did this, but we really truly feel that the questions that we asked probably did not actually get at the true issues going on. Sexual violence, physical violence, gender-based violence is always underreported, but that in particular we really feel is an underreport. And so one of the things in terms of future research, we really want to do some scale development work. All we need is some funding to do some qualitative research, to go into Jordan, do some research, do some content validity, face validity, and really get at that question of, are these questions really capturing what we're trying to get at? And taking into account the issue that duty really is part of a sexual relationship and those social norms in different cultures. So that's the long version of that. Do you have anything to add to that?
Well, adding to that, just one piece. Definitely it's underreported, but yet we have tried all the RAs. We made sure, and we looked into the literature that all the screening process, the interviews were done privately, and all our research assistants were women, and that was reported in previous studies that helped in revealing some questions. So that's some of the measures we took in order to have more reporting.
Beautiful work. Your video shows the possibility of burnout in the people that are doing the research. Are you doing something to make sure that the mental health of the research teams are?
It's a great question. So Dr. Milton Weinberg is one of the mental health experts I was alluding to. So yes, absolutely. So the study is done now. Our team, they've all found other jobs at this point. But we had a really incredible job as entire infrastructure and led by Dr. Kadra, and we worked really hard with our research coordinators, one of them who was actually trained in mental health herself. And so we had regular, constant sessions where people could talk through, the RAs could talk through how they were feeling, talking through sort of what they needed to do. There were lots of conversations about, okay, you have done a lot of interviews in one day. Yes, you could do more, but maybe take a break. And then we would do calls on Skype. We would have those conversations so we could get involved too. And Dr. Kadra took care of them as well from that perspective.
As much as we can.
Yes.
I'll turn this on. Yes, thank you. And just on the topic of mental health, your rates of incidence of depression quite high, and I can understand obviously some of the issues there. But did you ask questions on their outlook for the future? Were they hopeful, or did they think their conditions will be improving? Was this a pathway to a better life, or did they feel more or less trapped? Did you explore that at all?
It's a good question. I'm looking at our student team too, who have been looking at the data, and I'm trying to remember exactly how we worded some of those questions. We did ask an entire scale on post-migration difficulties and sort of hopes for the future. To be honest, we haven't actually gone through those data yet. But I will say that this population is incredibly resilient, not just of course, our sample, but refugees in general. And there's a reason we picked the name Aspire for this work in general. So I'll speak generally, but I don't think I can speak to it specifically for our data yet. Yeah. Adam, Melissa, do you have anything to add to that?
We asked one question about under what conditions would you be willing to return to Syria, and then we asked something about post-migration living difficulties at the moment. That's the question that comes to mind. I don't know if you have something else on that.
Okay, one more. Okay, we have time for one more question. Nice. Okay, Lisa, go ahead. Sorry.
This is really amazing work and so cutting edge and really so important. So thank you. I was really struck by, that the providers in Turkey feel stigma from working with the Syrian refugees. I mean, that's an amazing kind of finding. Is that also true in Jordan? And can you talk a little bit more about the type of stigma that they have?
We have no, I don't think they have stigma against working with Syrians, but there is a stigma, and we have discussed that in a previous setting with everyone. So our study was structured around Syrians, but also remember the areas from which we took our women has a lot of vulnerable Jordanian in terms of money, in terms of work, in terms of poverty. So one thing I was thinking about in our study was that we need to look into the host country. So we need to look into people, actually, not the provider. So, the difference between Turkey and Jordan, we are both Arabic descent, and there is a lot of relatives who are married in. So the number in Jordan, actually, and I was expressing that all the time, that we have only 600,000 Syrians. I don't think it is really an underestimate, because much of the Syrians are not registered with the UNHCR, right, because many live with their relatives and neighbors and that. So there is no stigma about working with the Jordanians. But what we are facing now, that some Jordanians feel that Syrians are getting more services, and that's why the policy has changed, and that's why being a country that faces economic crisis, that's a big burden on it. And, politics affect everything, research, lives, everything. Yeah. Thank you very much.
Thank you. Thank you.
And now I'm very excited we're going to jump to another country. We're going to start with, we'll continue with Turkey and our Providers Aspire work with. So it's a packed room. I just want to acknowledge the fact that so many people are standing and coming in, so thank you.
Hi, I'm Deniz Yükseker from İstanbul Aydın University. I'm going to tell you a little bit about our research in Istanbul, the Providers Aspire research. But before doing that, first of all, I would like to thank my colleagues at Columbia School of Social Work, especially Doctors Nabila El-Basel and Niraj Kaushal, but also Melissa and Anindita. Especially Melissa, we have really worked closely in this project, so we're really grateful, and we're really excited that we're part of this research. And when I say we, I don't only mean myself, but also my team members in Istanbul, who are not here today, Professors Uğur Tekin and Neşe Şahin Taşkın, who are actually in social work departments at İstanbul Aydın University and Maltepe University. I'm actually in the political science department, and I'm a sociologist, in fact, so it's quite complicated. Anyways, but I have been working on migration, so that's I guess why I'm part of this. Well, before telling you about the research itself, let me tell you a little bit about the context of the Syrian refugee presence in Turkey. Dr. El-Basel mentioned a little bit, but let me just reiterate that. So right now there are more than 3.6 million registered Syrian refugees. we say refugees because they are refugees, but in fact, legally they are registered under the temporary protection status. So they're not status refugees. And this number actually makes Turkey the largest recipient of refugees in the post-Second World War period. And Istanbul right now is the host to the largest number of Syrians within Turkey, as you can also see on this map, with nearly close to 600,000 people. Now, that doesn't make Istanbul the city with the highest concentration. In fact, provinces on the border of Syria, such as Şanlıurfa, Kilis, Antep, and Hatay, have much larger concentrations compared to their local populations, but Istanbul has the absolute largest number. Okay, and that actually made Istanbul a good site, reasonable site, appropriate site for this research. Well, why this research on secondary traumatization of service providers? Because civil society organizations have actually been at the forefront of humanitarian and social assistance in Turkey for Syrians. And people who work in them have been exposed to a lot of stress that stem from heavy workloads and being exposed to traumatic stories all the time. We knew that they were suffering from some symptoms, but in fact there were no studies about them. Although there are some studies on social workers and healthcare providers in Turkey and their experience of their cases of secondary traumatization, but there was no studies on service providers working with Syrian refugees. Okay, so that's why this research. Okay, well, I was looking for this slide earlier. These are some pictures of our team. In fact, Melissa and another member of the Colombia team, Filiz, visited us a couple of times in Istanbul, so that allowed us to design the research together, which is, and last year I visited Columbia School of Social Work before we started data collection. So basically we conducted a mixed method study, as Dr. Elbasel earlier said, and in a moment Melissa will tell you more about the quantitative surveys, the findings of that. We visited multiple sites of 17 civil society organizations and public agencies serving Syrian refugees, and we collected the data last summer, basically finished it sometime in fall. Now, we have this map here, which I'm very proud of. This is a partial map of Istanbul. On my left, your left, you see the European side of Istanbul, and the pins are, or the agencies were pinned on this map, and I'm very proud to say that we visited agencies in some of the westernmost districts of Istanbul on its European side, as well as some of the easternmost districts on the Asian side. And these districts are actually the districts that in which many Syrians live. They're concentrated. Okay, well, now first of all, Melissa will talk about the quantitative findings.
Hi, everyone. So following from the format of data collection, when we first collected the quantitative surveys before the qualitative interviews, we'll format the presentation in a similar way. So I'll present on the quantitative findings, and then Dr. Yüksekar will come back to present on the qualitative findings. I also want to take a particular note to shout out to the entire team, building off of Dr. Yuxucker's presentation. Really, this project wouldn't be possible without our investigators in New York at Columbia, Dr. Nabila El-Bassel and Dr. Neeraj Kaushal, as well as the three investigators that we have in Turkey. In addition to Dr. Denise Yuxucker, we also have Uğur Tekin and Dr. Neşe Şahin. And then I'm also going to take just a couple of seconds to shout out some particular students, so bear with me. Thank you. So Adam Brooks, Zafar Shamuk, Dr. Anandita Dasgupta, Alif Dembarish, Jenny Hartman, Kutai Kutlu, Trina McGeary, and I really also want to pay a particular thank you to the group of Columbia social work students who supported in a lot of the background literature review work that we did, as well as the RAs who were just incredible assets to this study. And then before moving forward, again, the study is looking at secondary trauma among providers, and so we want to make sure that we're all kind of on the same page with how are we defining secondary trauma, who are we considering to be service providers. So for the purpose of this study, we defined a service provider as somebody who works directly at least 50% of their time with Syrian refugees, providing direct care. So that's inclusive of people who, like social workers or psychologists or nurses, but we also included translators in this study, which will become more apparent as to why in the slides to follow. And then in regards to secondary trauma, we used the definition that secondary trauma are the impacts related to indirect exposure to difficult, disturbing, or traumatic images or stories related to the suffering of others. With that in mind, let's move forward to the quantitative. So when we're looking at the study population profile, what's most immediately apparent is the age of providers and the experience they have in their current position. So you'll note that the mean age was between 28 and 29, and the range, was from 20 to 47, but the age is quite young. And actually, the vast majority of the providers in our survey hadn't been in their position for more than a year, so less than a year for 51% of the providers. This aligns with what Dr. Yuxucker was mentioning earlier about the quick expansion of this sector in relation to the influx of refugees to Jordan, thus relying on a much younger workforce. Further, we know that a lot of the funding contracts related to services for refugees are based off of short-term contracts. So there's a lot of instability in the overall sector, in the service provision sector. It's also worth noting that while the majority of providers were of Turkish nationality, 15% of providers included in this sample were Syrians themselves. And this is something that's really important to take into consideration when you're thinking about the compounding nature of not only secondary trauma, but perhaps firsthand exposure to trauma. And then lastly on this slide, I want to draw your attention to this lower corner right here around supervision. We'll touch more on this in the qualitative findings, but I want you to bear in mind just the range of supervision available or perceived to be available by providers and how much that varies. When we're looking at the quantitative findings more descriptively on the client profile, most providers are working with females and with adult populations between the ages of 26 to 59. We didn't keep in here the population of 60 and older because it was a really negligible amount of providers. And something else that is really unique in direct service delivery in Turkey, and what I was mentioning earlier, is the use of translation to provide services. So you'll see here that 58.6%, so more than half of providers, rely on translation services, usually or always. And while the percentage of clients sharing trauma varies, we do see that traumatic grief or separation is the most commonly shared traumatic event. When we shift over to, I want to give another shout out to our team in Turkey because they did an incredible job of finding validated scales and number of mental health measures. And so there was a really key component of our quantitative survey was the capture of validated mental health measures. So as you'll see, the providers in our sample had lower compassion fatigue and higher compassion satisfaction, but really to a marginal degree, it seems. And in fact, these results are fairly consistent with the Yazil study conducted in 2010 with other aid providers in Turkey. When we transition over to PTSD and secondary trauma, I want to reiterate two things before kind of dissecting these a little bit. First, the secondary traumatic stress scale that we utilized had 3 distinct dimensions: re-experiencing traumatic events, avoidance of reminders, and persistent arousal. And I would ask for you to keep those 3 themes in mind, not only when looking at the scale, but more importantly with our qualitative findings as we see those themes reemerge. Again, they're re-experiencing traumatic events, I'm losing my place, re-experiencing traumatic events, avoidance of reminders, and persistent arousal. We also found in the literature that a lot of secondary trauma symptoms are similar to those in PTSD, so we wanted to be able to compare those side by side. We can see here again that our outcomes are lower than the reference group, though it's really worth noting that in the PTSD measure, the reference group is not directly related at all. It's Turkish students. But what is clear here is that there's a range in both of these outcomes. And what we want to tease out moving forward, as Dr. Dasgupta mentioned, we're trying to share this information as early as we can. But the next step for us is really to tease out this data and to understand better who is reporting vulnerability or resilience, to these outcomes, and what factors may determine or influence these scores. So in the final slide on mental health scales, I want to bring your attention to 2 slides that I think as social workers, as most of you are in the room, are probably very familiar with in our practice. So you'll note that nearly 40% of providers met the criteria for depression according to the CESD, and nearly 30% met the criteria for anxiety. As I mentioned earlier in the last slide, we want to tease out who is more likely to be reporting what, and so we have run some preliminary tests in the meantime, and what we've found is that there is a significant variance in anxiety between Syrian providers and Turkish providers, and there is a significant difference between those who have worked less than 1 year and those who have worked more than 1 year. But there hasn't, from the preliminary analysis that we've conducted, we haven't seen a significant difference for those who use translation services and those who don't. I also want to note that we asked about mental health diagnoses and found out that about 22% of the providers did report having a mental health diagnosis, and the most common was depression or anxiety. And something that was really reassuring to hear is that 18 of those 23 respondents indicated that they were receiving mental treatment or medical treatment for those diagnoses. And then the last component of this is shifting over to support. So thankfully, the team at Istanbul Aydın University was able to find 2 validated scales, both in organizational support as well as social support. And this slide looks at organizational support, whereby you'll see that the majority of providers feel that the organization cares for their overall well-being. However, when you look at these indicators, you'll note that, or hopefully you can see, that it's really more about appreciation the organization feels towards providers rather than the actual provision of support by the organization. So while this is really useful to know in regard to the perception or acknowledgement of provision of support by providers, we're thankful to have the qualitative study to actually dive in a bit deeper in the actual provision of support from an organizational perspective. For my last slide on the quantitative findings, we also asked about social support from family and friends. And what's most immediately apparent here is the reporting of availability of support from a network of friends or family. However, when we start to look at the availability of a single individual, in this instance, a special friend is how it was worded in the survey, you'll note that all of those indicators were the lowest reported ones. Thus, our quantitative findings highlight the availability of support, and the qualitative findings complement that by really looking into the depth of that support and who is providing what kind of support and under what conditions. So with that in mind, I will hand things back over to Dr. Yüksekir to review our qualitative findings.
Thanks, Melissa. Before I start talking about the qualitative findings, I think I was a little nervous at the beginning. I forgot to mention our research assistants in Istanbul, although thanks to Melissa, she mentioned their names. But I would like to acknowledge them too, Zafer, Kutay, and Elif, who have been really wonderful research assistants for the Istanbul team. Okay, the qualitative findings. Now, as we said earlier, we interviewed 28 people for the qualitative study. These people were a subset of the participants in the survey, and the demographic profile of them, as you see, is very similar to the to that of the participants of the surveys. Now, we asked them a set of questions on 6 themes, and I will be giving you a little taste of the responses, the findings for each of these 6 themes in this order. So starting with working conditions, as the survey findings also show, very heavy workloads are reported. So this heavy workload is not only about the number of cases that they see per week or per month, but it is also the emotional heaviness of the workload, because they are talking with traumatized people, torture survivors, or people who have fled the war, and so on. Now, I will be providing you short quotations from the interviews to give you a taste of our findings, but of course there's just so much more information. I would like to draw your attention to the first quotation here. This was a Syrian woman, and she said that her workload was exacerbated because she was the only Syrian in her agency, and we heard similar things from other Syrian service providers as well, because because of their language abilities, and perhaps also for cultural reasons, they had a higher workload. Okay, now given that their workload is high, in fact some of them said that this is not the kind of job you would do just for the money, or just according to the job definition, but it was something that required sacrifice. Here I want to point out the last quotation here. This was a man, a religious man who worked in a faith-based organization, who said it couldn't be just for the wages that they earned, not that he complained about it, but he said he basically implied that it was for a bigger cause, and he just assumed that God would provide for him. So hence the Turkish saying, "Rizq is from Allah." Okay, now given that the workload is quite heavy and also is emotionally heavy, were there what kind of mental health symptoms were they suffering from? We had some questions about those, and the findings show the findings are quite consonant in parallel with the responses for the scales on secondary trauma, or the scale on compassion, fatigue, and burnout. So again, I'm just going to give you a couple of examples without going into too much detail. For instance, quite a few people said they were burnt out, or they had periods in which they felt they were burnt out from this job. And why was that? Because they were just listening to a lot of traumas, which was emotionally affecting them, which was also creating emotional sensitivity. So one person said when she looks around, she always thinks about what kind of problems those people might have. So she was projecting the traumatic stories she heard at work to the wider population with which she was interacting. A couple of interesting things here. Melissa mentioned that there are 3 dimensions of the secondary trauma scale: re-experiencing, arousal, and avoidance. And in fact, these are themes that we encountered in the interviews as well. Let's have a look at this first quotation. So this person, this woman, had handled a intimate partner violence case during which she was quite affected by the story of the woman with whom she was working, and she was, at some point, she was also scared for her own safety, as a result of which she started having difficulty sleeping. And when we interviewed her, it was that incident had taken place about a year ago, but she was still reporting not being able to sleep much. But on the other hand, for some people, this overexposure to traumatic stories might lead to avoidance. So several people said that they were developing some kind of desensitization to the traumas that they were hearing about, or they no longer wanted to hear problems, period, or they were just avoiding to hear traumatic stories, as this second quotation shows us here. Okay, now, given that they have a heavy workload and they show some symptomology of secondary trauma and burnout and compassion fatigue, how does that affect their quality of life? So we asked them also questions on that. Now, this is quite interesting. Actually, the majority of the interviewees said they just did not want to socialize much anymore after starting to work in this job. They just wanted to be left alone. They were exhausted. They didn't want to do anything. So this was their response to working too much and hearing traumatic stories all the time. But fortunately for some of them, this wanting to be by oneself also led to taking up some good habits for their self-care, such as exercising or doing outdoors activities. But this was, although those people were not in the majority. Okay, now all these problems compiling now, then we were also wondering if they were getting supervision at work, professional supervision, but also individual supervision for their own emotional problems at work. The quantitative surveys showed that supervision was available but was not systematic, it wasn't regular. So likewise, the qualitative also shows that supervision is not regular. So it's not systematic. So these two quotations, just among many, show that it was on and off. Some program would start, but then for some reason it could stop, or its quality was not satisfactory, as this second quotation shows. Now, what do they do in the absence of systematic or regular supervision? They created their own mechanisms, informal mechanisms of guidance, which some of them called peer supervision. They could ask a more experienced person at the workplace about how to deal with a case, or somebody who has more experience, let's say a psychologist working with Syrians, could also advise her colleagues about their work-related emotional issues. Okay, well, were they getting social support, which is also something we investigated in the quantitative? Yes, social support is available. So that's what the surveys also show. But in the qualitative, we noticed that social support from family and friends might sometimes be compromised by prejudice towards Syrians that are held by their social circles. So here are a couple of quotations from two surveys, two interviews. So the first quotation, in the first quotation, we hear from a person who says her family is very supportive because they are also doing something to help Syrian families in their neighborhood. But other people around her are not so understanding of what she does because they think it's not worthwhile. Now, in the second quotation, we hear from a person who said that her parents they were very prejudiced against Syrians, and they questioned why she was doing, why she was working as a social worker in a CSO. Moreover, her friends were not that supportive either because they didn't have any idea about social work. Now, incidentally, this person had a bachelor's degree in French literature, so that, I guess, didn't help. Yeah, but well, that's another issue. I mean, not a majority, but some group within our survey participants and interviewees had degrees in unrelated fields. Now, but for a person who is a psychologist, and that's the second quotation here, her friends were really supportive because they all knew about what was going on. Or the first quotation is from a person who said that when her family is also understanding of Syrian refugees' conditions, that is something actually motivates her at work, although the work is difficult. Now, I started talking about prejudice, and I have to actually talk a little bit more about that because, and in fact, we did ask a set of questions on prejudice and stigma to our interviewees. You know, what were their opinions about how Turkish society views Syrians or how their social circles views Syrians. And one thing I have to say that, and I hope hopefully I'm not exaggerating because, of course, qualitative studies, the findings are not necessarily generalizable because you cannot test hypotheses with them, but they give us some depth of perspective. So social service provision to Syrians in Turkey is taking place within the context of high levels of prejudice, societal prejudice against Syrians. This high level of prejudice we know from our daily lives, but also we read about it in survey studies, and also in media studies, content analysis of media coverage. So there are a lot of negative stereotypes about Syrians. The notion that they live off government aid, the notion that they have fled their country and not fought for it, and so on. So what do service providers do with this within this context of within this environment? Well, some of them say that they try to explain to others that those stereotypes are wrong. But they also report that they constantly get the question, why do you work for them? Why is it worthwhile? Why don't you work for Turks? Why don't you help Turks instead of Syrians? So some of the service providers said that they patiently try to explain, but there were some others who said they ran out of patience. They no longer wanted to explain, and they were just avoiding the topic. Now, this second quotation here is by a person who told us that, in fact, this is common. It's a common conversation topic among service providers. What do you say when somebody asks you your occupation? Do you tell them that you work with Syrians? I guess it creates awareness among them, among social workers, that there's so much prejudice. Now, this woman herself said she preferred not to tell people that she didn't know so well that she worked with refugees. Just said she's working in a CSO. Okay, so I mean, what does and furthermore, I'm running out of time, but let me say this too. We also found out that a couple of the interviews also admitted to having prejudice themselves, or especially at the beginning when they started working in this area. But they were trying to they had overcome that prejudice by learning more about Syrians and their situation in Turkey. But nevertheless, a couple of people also acknowledged that they were, they were still having mixed feelings. Like this second quotation shows, this person said she's experiencing dilemmas. Okay, so as Dr. El-Basel said at the very beginning, this is quite interesting. So these people are working with a stigmatized group, stigmatized population, because there's so much prejudice against them in the country. And the work they do, therefore, is also somewhat stigmatized. And furthermore, some of them themselves might have prejudice. So again, I don't want to generalize, but this was quite an interesting finding that we will have to explore more in the next few months. Basically, what we want to do is we want to bring our quantitative and qualitative findings into more conversation with each other to identify, to analyze which groups are more vulnerable to or more resilient against secondary traumatization. And by doing that, we want to actually disseminate our findings among agencies serving Syrians in Turkey to raise awareness about this issue, about secondary traumatization. And hopefully, if possible, we would also like to develop a training for service providers so that they can cope with this issue. Okay, thanks a lot for your attention. So I guess now we have a few minutes to take questions, if you have any questions. Okay, yeah, like this. No questions.
I have a question. So actually it was, to be honest, this is the first time I hear the news from Turkey. And it comes really shocking for me how much stigma and prejudice.
It's really
Syrian. And I know we are in the initial stage of the research. But when we first started the study, we always believed that integration is the solution. So how do you go through, if the providers themselves feel that stigma and that prejudice? I know it's too early, but have you thought of ways to change that in order to change the society?
To change what?
Like the providers themselves, they have feeling of prejudice and being, stigmatized by working in Syria. So do you have a clue of how we can exactly change, how we can help the providers in changing that? Have you thought about that? It's really shocking the amount of.
Well, I think this is you just opened a can of worms. Well, first of all, I don't want to say that our respondents were all of them, or even most of them, were had stigmas towards Syrians. I don't want to say that they were actually very devoted people. They were quite devoted to their work. But it is a fact that there's high levels of prejudice against Syrians in Turkey. I'm not saying this off the top of my head. Studies show this, unfortunately. Now, have I thought about anything? Not necessarily, but I don't think this is unfortunately not a problem for for service providers to solve. This is a broader social issue. That's why it's a can of worms. In fact, there is not much public debate in Turkey about the presence of Syrian refugees, their conditions, and the fact that there's more public debate about the war in Syria rather than Syrian civilians in Turkey, So if we could open a candid debate about this and raise awareness about their conditions and their problems and so on, that could open a way for integration. And as I said earlier, I'm a sociologist, so integration is not only cultural, but it's also a structural issue that requires legal steps, legal equality, legal inclusion, and socio-economic inclusion. And those are things that that a state is responsible for. And to be honest, the Turkish state has started to take steps in those directions, but we're still at the beginning. I mean, there are hundreds of thousands of, about 400,000 Syrian kids. They're still out of school. Most Syrian adults work informally and so on. So integration is, there's a bigger picture of integration that cannot just be addressed through such a study.
Hi, thank you for your presentation. I'm curious about the kind of training that social workers in Turkey receive. I'm taking a course on the Jordan refugee response right now, and we've learned that the type of training for social workers tends to center more around case management over like clinical training, and how that sort of impacts the people who are providing those services. I know you mentioned that a lot of the providers that you interviewed, a lot of them had unrelated degrees, had bachelor's degrees as opposed to graduate degrees. But I was just wondering, you know, how that, like the kind of training that some of those social workers may have received and how that impacts their ability to function in a healthy way in their jobs.
Well, the agencies in which they work provide them with on-the-job training about case management. But our respondents reported that sometimes the guidance that was given by the management of the agencies was not sufficient. In some agencies, they said it was not sufficient. So they were sort of left on their own to find out what kinds of things to do. Now, it's quite interesting. If my colleagues, other team members, Uğur Tekin and Neşe Şahin, were here, they could address your question better, because they're in social work. And one of the strange things is that some of these CSOs, civil society organizations, actually do not, they employ only a few social work graduates, but just they employ people from a wide range of educational backgrounds. So there's a problem there which needs to be addressed, but I don't necessarily have an answer to that myself here. Maybe one reason why they employ people with other degrees is that those people might have had prior volunteering experience in CSOs, so that might be useful. But this is actually a question mark.
Yeah, and let me know if I'm misspeaking, but also just in regard to the field of social work in Turkey, it seems to be growing quite exponentially. There's definitely a vested interest in social work. In fact, some conversations that we've had, particularly with Dr. Tekin, who's the in-country PI for this project and is a social worker himself, the conversations that we had with the whole team about how these schools of social work also are increasing across Turkey, and actually the supply of professors or instructors is not meeting the demand for potential incoming social work students. And there seems to be and this is the part that please correct me in misspeaking, but there seems to be a pretty strong linkage with the social work profession in Turkey and its growth, much similar, probably most compatible with the system within Germany, wouldn't you say? Which is very closely related to the US and the UK's construction of social work. So in regard to the overall profession, it does seem to have a broader scope than overall case management in theory, but also in practice, what's happening at the agencies and what sort of delegations of work responsibilities. It may, in fact, be case management. That's something that I don't know.
I don't know either, but what you just said reminded me of something. In fact, last year the annual National Social Work Congress was devoted to social work and migration, in which Mills also spoke.
Yes, sorry, I'm just going back and forth. But it also just highlights too, like how much of an interest in the social work field and direct connection to the Syrians in Turkey. How closely linked that is. I can't really imagine in the U.S. having like a social work conference distinctly related to forced migration. Though that would be fantastic. I'm not familiar with that happening.
I have one. Oh. Hi there. Thank you for this work and sharing your work and the passion around that and thinking about providers. I was wondering just some thoughts. It sounds like you're looking at protective factors as you're doing both your mixed method. What are some of those predictors of protective factors that that we can like build on? And are you looking at, for instance, motivation for doing this work is one of those, and maybe others like theoretical framework that they do their work under. In other words, what guides them, that kind of thing. I wondered if that might be interesting. And then if you're thinking about intervention, is that the goal with your data? Do you have partners in country, for instance, the field of social work or even psychology? I know there are some progressive work in Turkey with motivational interviewing that's taking place, and I wonder if those partnerships are kind of growing, or the potential for those to do intervention are growing. Can you see them, that potential there?
What study are you referring to? You said there's a progressive...
There's training in motivational interviewing that's been done in country with several institutes, and I've had some dialogue with them. I was really impressed with just their framework, their client-centeredness, and I thought it would just be a good partnership.
Well, to be honest, I'm not aware of them, and maybe after this event, I can ask you about who exactly those research teams are. But yeah, it's important. I mean, their motivations for doing this work, that could actually explain something about how to protect people, protection from or prevention of secondary trauma.
Yeah, and part of I think that's a really great concept to think about, like, the overall motivation. It's not something that we've talked about, but that is a fantastic idea. And part of also what we wanted to look at was kind of existing systems and how that may influence outcomes. And that's with us when we're looking at support in particular. If having more regular or effective or what have you organizational support or supervision, like what sort of role would that have, or perhaps like social support, linkages with friends and family, how could that perhaps mitigate the impact of working with clients who are expressing a lot of trauma and a number of the mental health outcomes?
I want to understand, like one interview you talk about the cultural similarities between Jordan and the Turkish culture. Can you talk about it?
Why did we talk about it, or why didn't we talk about it?
Oh, no, just like one interviewee talk about, she realized that there's so many similarities between culture, like between Syria and like Jordan citizens.
Well, of course, I mean, both societies are overwhelmingly Muslim. That, I guess, that is one potential cultural similarity. But that interviewee was actually someone who was more religious, and elsewhere in her interview, she said that the road to integration could go through being Muslim. So Islam or religion could be the basis on which we could build integration. I think that's the context within which she was talking about that. But in fact, there are surveys which indicate that Turks don't think that there's much cultural similarity between Syrians and Turks.
I think we'll have to close on that last question. Oh, we do? Okay, great. Okay.
Hi, thanks for sharing. I'm curious about, I know that there are only 15% Syrians that were practitioners, but I am curious about if you saw a difference in the impact of the interviews on Syrians versus Turkish practitioners, and like if for the Syrian practitioners that caused additional trauma or re-trauma, and if for given the conversation around stigma, whether like how you saw that play out in Syrian versus Turkish practitioners.
I could say something about that, but maybe you can start. Okay, about the last part of your question, there were only 2 Syrian interviewees, but 15% of the survey. It was quite striking. Actually, both of these Syrian interviewees expressed more symptoms of being burnt out and so on. And in fact, as Melissa said, you said that in fact the Syrians within the survey had a higher score of anxiety. Now, about the stigma, they were also having to deal with on a daily basis. I mean, one of them said that she doesn't, when somebody asks her what nationality she is, she doesn't, she wouldn't say her nationality unless asked. And then she criticized other Syrians for pretending that they were Palestinians. So, I mean, I think they suffered more from this prejudicial environment. And they were probably also had war traumas themselves,
And then just kind of transitioning that as well to the protections within the survey and administering the survey. So that's one of the many advantages of working with the social intervention group and with such great colleagues at Istanbul Aydın University. So the training of providers, much like our team and Jordan was mentioning, underwent really rigorous training in how to conduct interviews, under what conditions to continue or perhaps cut them short, to provide referrals when necessary. I mean, those provisions were certainly put in place and a top priority for us. And something else that I think is really notable for the research assistants that were collecting the data in Turkey is that all of them were either current or graduate students associated to the universities that we had worked with. And most actually were PhD students or had graduated. So there were individuals who had pretty thorough experience with research, in part because of the concerns that you had that we didn't want this to be taken lightly. Yeah. But I think we should close on that one. Thank you so much.
Thank you very much.
Great. So I hope everybody has enjoyed these last 2 hours. I know I felt like it ran by very quickly. I want to acknowledge again the fact that the funding for today and making this happen. I hope everybody enjoyed the great food and beautiful flowers outside. And also I wanted to highlight that we have this incredible Katya, can you wave? This incredible display that Katya Mikolopoulos made as a senior thesis project from the Fashion Institute of Technology last semester. And it's this interactive display outside in case you haven't gotten a chance to walk through it and learn more about our work. So we really appreciate that. I thought I'd start our closing with, again, some more thank yous. We're a very grateful group, in case you can't tell. So we've acknowledged a lot of our partners in different countries as well, and our funders, and also I wanted to mention just also our co-investigators in Jordan, Dr. Ruba Jaber and Dr. Rayed Al-Khattab. And then finally, our research coordinators in Jordan, Luma Samawi and Yusra Al-Salman. So as we're wrapping up, I also want to just finally acknowledge our own team as well. We've heard their names again, but Melissa Meinhardt's been the project director of our Aspire initiative since the very beginning. So I want to acknowledge that. Mohammed Adam Brooks has been instrumental in everything, and our timekeeper, Jenny Hartman. Where did she go? Oh, I think she had to go to class, so that's good. And Trina Mukherjee and Hani Almosh. So thank you very much. I'm not done. But we can clap for them. I just want to end, Dr. Kaushal mentioned that our idea for Aspire really started in passion, right? We really wanted to do work that would create a meaningful difference. And in a couple years, we've created an incredible collaboration, and I think that's very clear, right? Global collaboration takes effort, takes work, and I really think that we've done an incredible job, and I see a huge future for that. We really, truly aspire, pun intended, we really truly aspire to see a day when Syrian refugees and those delivering services to them see a happy, healthy, peaceful life. So thank you all for coming, standing, for those of you who are standing, and those of you who are joining online. Thank you.